if you estimate 1 in 10 people has a need out of a million people, that's a lot of people. That's 100,000 people, right? And let's say half of them actually seek services. 50,000 people for one psychiatrist. It's not possible. It's just not possible to meet that need.
Welcome, everybody, to another episode of The Force for Good. I'm Rick Gertsema, and I am the Senior Mental Health Advisor at the Miller Dwan Foundation and Archimind. And today, I'm joined uniquely by two colleagues, both of whom have extensive global experience. And Annie is our program manager at Archimind and has extensive experience with the U.S. government. And Dr. Brandon Gray is part of our Archimind Strategy Council. He also has extensive experience and has worked with the World Health Organization, which is part of the work that we've been doing as we're bringing in interventions into the United States that have been tested in other countries globally. So what I'd like to start with is, Annie, if you would like to introduce yourself and let our audience know a bit about the work that you've been doing or have done. And then Brandon, I would ask you to do the same. So go ahead, Annie, if you'd introduce yourself, please.
Sure. Thanks, Rick. My name is Annie Schwartz, as Rick said. I have been working mostly in the global health field for about 25 years. I have worked with USAID, Peace Corps, State Department, both in country in South Africa and Switzerland, and then back in the United States, primarily on HIV. There was the President's Emergency Plan for AIDS Relief. PEPFAR was the large U.S. government program to fight AIDS around the world, and then also have worked on maternal, newborn, child health, and other different infectious disease programs.
Wonderful. Thank you, Annie. And Brandon, if you'd introduce yourself, please.
Sure. Thanks, Rick, and nice to be with you here. My name's Brandon Gray. I'm a clinical psychologist by background, trained in the United States, but spent most of my career working in mental health and psychosocial support in different countries around the world. Most recently with the World Health Organization for about 8 years. First in WHO headquarters in Geneva, Switzerland, supporting different countries, and most recently in Ethiopia with WHO. Before that, I worked in different international NGOs. So my focus and experience is mostly in taking what we know about mental health and trying to make it work in different countries.
Beautiful segue. Annie, I'll start with you, and actually, even the two of you may just want to exchange some dialogue here. When I started with the foundation and was looking for, we had an initiative called HopeX, and the work was really around how can we help solve the mental health crisis. And part of what I did then was start with the Pan American Health Organization, which led me to the World Health Organization, which led me to New York City. And in all of those contexts, we were talking about a reverse model of development. And I'm wondering if, Annie, if you want to start, Brandon, if you want to start, really helping our audience understand why we really call this a reverse model of development for the work that we are bringing into the U.S. context.
Sure, I can take a stab at that. We often think of development as taking lessons from the global north or models and implementing in the global south. But I think that's a very one way view of it, and that a lot of the work, it should much be more of an exchange. Coming from Peace Corps, that's one of the tenets of Peace Corps, is that it's an exchange between, two different countries. And back early in the HIV crisis, I think the work, this President's Emergency Plans for AIDS Relief, was doing really focused work most in Africa, but really pouring a lot of effort and working with these other countries. And the science was, and the programs were developing much faster than we were looking at in the United States. And we kind of fell behind. So I can't remember what year it was, but we did a panel at the International AIDS meeting that happened to be in Washington, D.C. about this exact issue. The the model that we were using in international development, it was called the three ones, that you needed to have one coordinating body, one HIV strategy, and one monitoring and evaluation plan to be have a successful HIV program. We weren't actually doing in the United States. We had multiple models, multiple agencies working on it. And so we were just pointing out, like sometimes we are doing better work in the in different countries than we are here, and that we need to be looking at it as an exchange and trying to figure out how we do things better together. I mean, I think COVID was an example of that, that we were, working together a little better to advance the programming and science. So I think it's not a new concept. And we really need to be thinking, how are we looking at all the different models in the world, and how are we applying them as best we can? I think in the US, in that time, it was around 2008, I believe, DC actually had an HIV epidemic. The rates of HIV were about the same as Rwanda, but we weren't looking at it that way. And so, like, thinking we're not we're not immune in the US. We don't always have better programming. I think that we're seeing that with mental health. I think we assume that we have the systems in place that we need, but we don't. And I think the statistics show that the mental health crisis in the US is getting worse, and access is limited. People are not accessing what they need. So really looking at these other models in other countries and how they're expanding access.
Brendan, anything you would add to specifically with the reverse model of development with regard to public health and mental health?
Yeah. Yeah, definitely. I think Annie said it very well. And if I look at the other side of, why is there such a model that we use in different countries around mental health? We call it scalable interventions. A lot of it was born out of a program that WHO has called the Mental Health Gap Action Program. And the reason this program was made is really born out of necessity. And the fact is that in most low and middle income countries, there aren't enough mental health professionals to actually provide services to meet the needs of everyone who has a mental health problem, right? So in many countries, there might be one mental health professional per 100,000 people, or even more. Sometimes it's one per 1 million. The example that's often I can give actually in Ethiopia, it's about one per 1 million people for psychiatrists in terms of availability. So, if you estimate 1 in 10 people has a mental health condition, in some of these countries we're talking about, there are a lot of emergencies, there's conflict. We know rates are even higher than that. If you estimate 1 in 10 people has a need out of 1 million people, that's a lot of people. That's 100,000 people. And let's say half of them actually seek services, 50,000 people for one psychiatrist. It's not possible. It's just not possible to meet that need. So we have to find ways that you can make mental health care more accessible through a concept called task shifting or task sharing, which was actually born out of the HIV field. How can you make it so that interventions can be applied by people who don't have as much specialist training and background, but still can be effective to make a difference in someone's life and improve mental health and well-being? So that's the whole model, right? It's a necessity to meet the gap of providers that exist. But actually, we have that same necessity in the United States. There are, I think, over 100 million people in the United States who live in areas that are designated as mental health professional shortage areas. So we see, in many of these areas, huge wait lists if you want to see a psychologist or a psychiatrist, let alone the stigma that comes with actually seeking formal mental health services, right? So what we can learn from a lot of these models of trying to meet that gap is that actually what often works is shifting to a workforce that is more close to a community, maybe community health workers, community health volunteers, they're called in some countries, different models, maybe religious leaders. They can be trained with brief interventions that have been distilled to the most core effective elements, and then applied, and they can be supervised by the specialists, so that someone with a more complex concern can be referred up the chain, and you can meet a wider range of needs, right? So you can make care more accessible by having these non-specialists providing the care, supervised by specialists who then take on more complex cases, and you develop this sort of stepped model of care. And even beyond that, promoting things like self-help can be really useful. So you kind of make mental health services at some way more reaching more people. We can do the same thing in the United States, and actually we need to, because we know that we don't have enough professionals to meet the need. And that's really what we're talking about here, is how can we learn from what's being done.
Correct. And I think, Brendan, you were part of the work with one of the programs that Archimind has brought to the United States. Well, you're probably involved with more than one. Specifically, I'm thinking about Problem Management Plus. Can you talk a bit about that development and the work that was done with PM Plus globally?
Hmm. Yeah, so PM Plus I've done more on the implementation side. It was a
Okay.
little before my time with WHO when it was developed, but Self Help Plus is another model that I was more involved in development and then the implementation of. But I know the idea is exactly the same for both. It's that
Yes.
PM Plus is a one-on-one kind of intervention, 5 sessions where you can train what we call a helper to provide the intervention over 5 sessions with sometimes a peer. The helper can be a member of a community, they can be a member of the same organization, they could be someone who's already providing a different service, like a
Hmm.
social worker or something like this. So it's an intervention that's all around what it sounds like problem management,
Yep.
plus dealing with the impact of the problem and how it impacts your functioning. So the idea is actually you can't solve all your problems, and many mental health problems, as we know, are actually born out of the social and the environmental circumstances we live in.
Correct.
Poverty. I don't have enough money to feed my family. I don't have a job. Maybe I have a health condition. Maybe I lost someone. All of these daily problems can be very impactful on how we think and feel. So Problem Management Plus is a supportive way of trying to find solutions or management approaches to problems when you can't solve the problem, but you can maybe manage how it impacts you.
Yes.
And that then has a downstream effect of also improving your mental health. And that's the idea of it, was making this kind of problem problem it was born out of a problem solving counseling, but making that more scalable. So making it so that someone with no mental health background, with maybe a week or two of training in the intervention, can actually then apply it and reach a lot of people. um, some very smart people at WHO started this whole idea of developing these scalable interventions. PM Plus was the
Hmm.
first one, led really by Katie Dawson and Richard Bryant and Mark Van Olmeren, my former manager at WHO. These people were really thinking very innovatively, like how can we shrink the gap by relying on non-specialists in mental health? And they thought, well, this is a common issue, right? These economic and social problems. So let's create some kind of intervention that can be done in many countries and in many settings with lay workers, and then see how it works. So they designed it, they tested it in multiple settings. Actually, a rule for WHO interventions is that they have to be shown to be effective in at least two what we call randomized controlled trials. So showing that compared to care as usual, they're more effective in improving symptoms and functioning. And that happened with PM Plus. Actually, I think it's been in something like 20 RCTs now. So it's very effective across many different settings and in many countries. So that was really the starting point. And then since then, there's been a number of other scalable interventions that you're also working on as well at Archimind. Ease, Self Help Plus, which we can talk about, but they're all designed in this way of creating this kind of layered system of care that doesn't rely entirely on the specialist.
And so from that global context. Thank you, Brandon, for that, because I think it gives us that bigger picture. And when I started doing work with the Miller Dwan Foundation, which then turned into Archimind, there was a pilot project in New York City called Recoup New York. And it was really the first city to try to do that randomized control study. And then the data was sort of born in the US. We were invited as a second city, Annie. And since you've joined, to Brandon's point, we talk about, this tiered level. We've talked about PM Plus. In your role as program manager, you really are now that sort of coordinator of all of these programs, and thinking about what have, what are we learning, and how do you see us moving forward with bringing these global interventions into the United States?
Yeah, I mean, I think kind of playing on what Brandon was saying, there's a bit of a hesitancy to roll out um, these lay worker or scaled models. But I think because harm there might be harm to individuals, or that people are scared that there's not that there could be negative effects. But I think the negative effects are not having these interventions. So they're already happening. People are having mental health crisis. So we really need to get these to scale. And as Brandon said, WHO doesn't put their stamp of approval on things unless they're tried and tested. So I think we need to move forward on scaling those. And I think we've had quite a bit of success, as you said, Rick, in this pilot. So New York has done more of that large scale randomized control trial, but even in Duluth, where we've been replicating it, we've seen very similar results in reduced anxiety and reduced depression of individuals going through PM plus. And as we talk to community members, PM plus, it's a 5 session model. That might not be a fit for everyone. So we've done a lot of work to figure out how do you work with organizations to even do something like maybe that's not the exact right model for everybody. So we've really developed this menu of services to help reach as many individuals as possible. So maybe they start with very light touch. We've been doing psychological first aid, which is more of an awareness. We did it with the Minnesota Loggers Association. So we've just trained 500 loggers. They are not in a place where they are sitting down to do 5 session interventions, but they do need that awareness. There is an increase in suicides within the industry, and really needing to start somewhere. So we're starting with the psychological first aid. What are signs of depression? What are very quick things that you can do as an individual? Um, Brandon mentioned Self Help Plus, just getting some of these resources in individuals' hands so they can start somewhere. I think there's still a lot of stigma and access issues in the US to get the care people need. It's expensive, there's long wait lists. Like Brandon mentioned, the access, especially there's a lot of individuals living in areas where there isn't quite the right access. So these interventions are really a tool to get skills in the hands of people who may not have access to what they need. And we're seeing very good results.
And so when you think about, and both of you, when you think about what would be the two biggest challenges taking global interventions and bringing them into the US, what do you think are the biggest challenges that you would see? Because there's such different systems and such different infrastructure, from global into a US context. And so, um, talking about what those challenges might be, and then maybe thinking about what some solutions or what might be some creative things that Archimind has been doing. Brandon, if you want to start.
Sure. Yeah, thanks. I think Annie mentioned a good one already, and this is that people are hesitant. Actually, when we try to do these scalable interventions, In many countries, the most resistance comes from mental health professionals. Actually,
Oh,
because they're worried about harm, as Annie mentioned. Can people really do this safely? And also, it's a bit of putting me out of a job is sometimes a perspective that people have. That's not true because, like we were saying, there's a huge need already. So there's enough need to go around, unfortunately. But this is one thing: huge resistance from specialists, and often specialists who are part of policy making or decision making. Right? They're just not sure, not convinced that it can be done safely.
right.
Um, that's one, and I think for solutions to that, actually, there's a lot that can be said about how there's still a huge role for the specialist in these interventions, right? So they should never be done where it's just train a few people who don't have background in mental health in the intervention and let it go. No, no. There has to be supervision and ongoing monitoring and quality assurance, and a system where someone with a higher level of need can easily be referred to that specialist. So the specialist still has a very important role. They see more complicated presentations of different mental health problems. They're there to provide daily support to the non-specialist providing their intervention. If they have a question, they see a challenge. So the specialist still has a key role, and that's how we ensure quality and safety.
Hmm.
I think another piece of that argument is that actually what we're training people to do is not actually that complicated, and it's the type of things people already do. When we talk about PM Plus, you have a friend who has some sort of practical challenge. Many of us will listen and then try to help them solve that problem in some way, give suggestions, give space to discuss it. This is actually just giving a framework of how to do that better, right? How can you actually know some steps to take when you have that conversation with someone? How do you have a structure around it that's actually preventing harm, because you're not saying some things that sometimes can be harmful. When we dismiss someone's feelings, we don't validate their experience, we assume we know um, how they're responding to a situation. This is a big part of psychological first aid that Annie mentioned, is actually just
Hmm.
teaching people how to use the natural skills they already have. So that's another element. Is actually, we're not giving someone with no background in mental health the ability to prescribe very adverse medications that have high side effect profiles. No, that's not what we're doing. It's actually natural skills people already have, just putting a package and a structure around it, and building those skills a bit. So I think that's another argument that can really be made and shown through the interventions and what they actually are. Um, so that's the one barrier I'd mention. Another barrier I think that's maybe unique, not unique to the United States, but unique to each country, is regulation. So then
Oh,
it's around like who can actually provide what. And if you call something a mental health intervention, then who's licensed to provide it? Who oversees that provision? Can we categorize it as something like life coaching or something else that's outside of the formal health system? So then it's easier to access, less regulated. But then there's questions around that, around qualification. So, and every country is different in this way, and like deciding what's the workforce that is where it's okay to provide this intervention, and then who regulates it. Some countries it's not such an issue because there's actually not very much regulation, so it's easier to create some kind of new position
oh,
or new
yep,
new profile around that.
yep.
Um, and, and so then often the barrier is often resources, or just having, and the ability to hire a new workforce. In the US, I think it's not going to be, resources will be an issue in terms of finances as well, but I think regulation is actually one of the bigger barriers. And that's a challenging one because it's maybe state by state where you can decide who can do what. But if you already use a workforce that has some kind of permissions or licensing to do something in this realm, I think
Yep.
that's one way. So social workers are not they're specialized in their area of work, but they can also add this kind of intervention to what they do, and it gives another way of reaching a lot more people. You can think of other type of workers to case managers. You can so I think there's solutions that way. You can add it on to work that other some of the examples from Recruit, for example, for what you guys were doing there. You can add it into the work that is already related to what an organization's already doing, but it's a more complicated aspect of the
Right.
implementation. Yeah.
And Annie, for you, I think about you really are you sort of are the boots on the ground and the person who is doing pre-implementation work and doing all of implementation, pre-post training, and so as you are so close to the work, what do you see as the challenges in the U.S. context, Twin Ports, or the work that Archimind has been doing nationally?
Um, I think kind of building on what Brandon was talking about, the regulations, I think it's just that coordination. There's so many players. There's 3 or 4 federal agencies, SAMHSA, HRSA, CDC, there's state, there's multiple agencies at the state, county, city. So it's like these organizations are having to navigate the funding and just getting buy-in from all these different organizations. And I think funding and sustainability is a big issue right now. Um, Trying to get this work funded in a sustainable way. I mean, it's a pretty low cost intervention, but still, I think in social services right now, funding is difficult. And I think the last thing I would note would just be I think across the US workforce, there's a lack of workforce in a lot of different sectors, and social services is the same. Part of that is due to pay, but it's not all related. It's people just are not able to find enough workers, and there's a lot of turnover in these positions. So we can get this model, people train people, and then they move or leave the position. So it's like just trying to keep that model going in a sustainable way within these organizations, which I think just is definitely doable, but takes a little bit more leadership um, and buy-in from the top levels.
Sure, sure. So we know the challenges. We're learning the challenges. What what excites you most, both of you, about bringing this work into the United States? Why are you invested in doing the work of being part of Archimind, being part of something that's bold, innovative? It's not being done in the United States, although we do have evidence globally, and now getting evidence in the United States. What really excites you and drives you and says, "Yeah, this is the work that I want to be doing." Um, Go ahead, Annie. Why don't you start this time? What drives you and brings you excitement about this work?
I just see so much value in it. Obviously, we've talked about the need. I mean, people are struggling. There's a lot of issues that people are struggling with now, and getting these are skills that anybody can use in their life to manage their stress. So I just feel like this model is so sustainable and just so needed at the moment. And we are seeing a lot of success. The people are we're training helpers to deliver this, and even the helpers themselves are saying, "Oh, I needed this myself," much less the clients that I'm working with. So I feel like the demand is there. It will really be helpful, especially as we get it to scale. I think when you get it to a community level and people are seeing that they're able to help each other, that creates a sense of community. And I think there's a lot of research that sense of community helps us all rise together. So that's what excites me.
And Brandon, your role, you're part of our strategy council. So our strategy council is made up of people all across the United States. Um, you certainly, what's really unique actually is that you both now are in Duluth, which is fabulous. So we have all this global that now is, we have Archimind, and then we have 2 people right here in Duluth. So from your perspective, Brandon, from a strategy council member and being familiar with the work, what excites you about being part of the strategy council and then bringing these interventions into the United States?
Yeah, thanks. Yeah, it's such a small world sometimes. But yeah, I'm interested in what you guys are doing and supporting any way I can. And the reason being that I guess why I'm in mental health in general. There's so many people who are suffering, and looking for some kind of support, some kind of solution to that. And it's the same issue we were talking about why these interventions exist in the first place. There's just not enough specialists. Not everyone needs a specialist. Not everyone needs to go to the health system, right? Not there are many ways to improve that, to reduce suffering, improve mental health and well-being. And for me, that makes, like Annie was saying, a better community, a better society. Our country is going through a difficult time, and it has been for a while. And if we can all be feeling better, functioning better, contributing together to a better community, whether that be on a very local level all the way to the national level, for me that matters more than anything. So if we can do something about changing, in some small way or a big way, the way people are experiencing, the thinking, behaving, relating to each other, relating internally, it really, I think, matters a lot for development of the country, and our country has a huge influence on the rest of the world, right? So it matters for other countries too. So for me, it's extremely important because it lifts all of us. Yeah.
And I think you summarized really nicely why really the birth of Archimind, and thinking about this big, bold vision that started with how do we really begin with being part of solving a mental health crisis. And here are two people who now are part of what Archimind is, and we're really learning. We're nimble. Uh, we know that there's more to learn. There's always going to be more to do, and the contributions that we get from that global perspective and that whole reverse model of development and people who have that experience, I couldn't be more grateful and actually flattered to be surrounded by such smart people all the time. It's always good to be surrounded by smart people, right? And so thank you both for the work you do. Thank you both for your commitment. And I'm so pleased that to have both of you be part of a podcast in which we can also continue to spread the word of the work that we're doing, because we are making an impact and we are making a difference. And so with that, we'll wrap up for today. And I thank you both for joining us. For the audience, we're available on all social media. Go ahead, take a look, take a listen, and please join us in being part of the Force for Good.